want to either get to this target, this thing right here, or if you're really curious about, well, what is this primary thing? Let me go back to, went the wrong way. This thing can be easily taken out along with sampling these nodes through the chest in this direction with something that's known as VATS or a thoracoscopic procedure. So we can put small cameras in, that you're on your side, kind of like I put that picture a minute ago. And the small ports have a high definition imaging. Put a small hole here, small hole in the back, small hole in the front, and we work between those, and we can take that lesion completely out. Got plenty along there. Just wedge that out, give them the whole thing, because that's scarier looking to me. That could be a primary lesion, which all of this bronchoscopy and stuff didn't produce anything. You with me?
Right.
In fact, what he was sampling, he said, was over in the left lower lobe. This is over on the right side.
Right
If you-
side, which side would that be on me on this?
Right here.
Are you right-handed?
Yes.
It's that side.
Okay.
Well, you were left-handed, now what would you say you,
Well, I just want to make sure you know your left from your right.
I didn't know you were.
So that big area
Looking
up there,
straight
you'll
on.
get us.
Well, if I go through the right chest, I can get everything. I can take out lymph nodes that are normal. We do lobectomies for cancer. We do, all types of the surgery through these small ports. But that you sleep on your side, and you would stay in the hospital probably at least a day. In fact, living where you are, we'd probably be there 2 days, because you go from ICU recovery to the floor, and the next day would be the second day you can go home. You have a small little tube about the size of a number 2 pencil, and we take that tube out when you go home. It's not a big operation for you. I mean, it's not fun, but it's tremendously better than where we were years ago. And this is something I do all the time. This is not an occasional thing. This is a standard thoracoscopic procedure. Now, alternatively, before you hold that question, if you just want to take the chance that we can get a diagnosis and make something out of this madness, is called a mediastinoscopy, which can be done with an afternoon stay, but it's making an incision right here, a little smiley face, right between those little areas right there, right above that notch. Again, you're asleep. But you do it, usually it's a whole afternoon. You stay in the hospital and go home that same day, but we put a rigid scope down in front of the trachea, into that tissue. Once we get about this far, which is not going to take long because it's only a few centimeters below this notch, and right off to the side under direct vision, we actually physically take out pieces, a few chunks of this, and we give it to the pathologist.
That's what he was talking about us doing, Dr. Nutley.
Well, you got the two options. The thing is, if this doesn't tell you very much, then you're still kind of wondering, well, what is this? The thing about going thoracoscopically, of course, you don't even have an incision like this. But you have this completely removed, and not only get that mass, but you can sample this tissue as well if it's necessary at the right island of the lung.
I know do.
Bang, bang, bang. There won't be anything left to go back and look at.
I know just go in. Do that
But
and get
I'll tell you
over
what we can do. We don't talk to him. From your perspective, it probably doesn't make a lot of difference. If you're not spiritually opposed to having a thoracoscopic procedure, then once we talk to him, whatever we schedule, they're just going to call you and tell you to schedule for procedure at such and such a time, such and such a date. Dr. Brothers is selected, and you say yes or no. Now, before you get here, before we even get that far, we would probably have Tom weigh in on this and tell us whether he feels strongly one way or the other. If he says, all I want is that node, fine, we'll drop back and we'll do what's called a cervical mediastinoscopy.
That's what I thought you were going to do.
well, the thing
If
about
we
it,
do
if you
a-
got that bottom thing though, you still got it if he does all that.
Well, I just don't know, I don't know what that is.
What's the least dangerous? I mean, you know, what's,
In my hands, they're both very safe.
are they? Okay.
They're very, very low
And
numbers.
recovery's low, I mean, real fast?
The difference, a mediastinoscopy would be if there are no issues, they'll sit around in same day surgery for 3 or 4 hours afterward, have a chest x-ray, and be able to go home. If we do it through a small scope, you're gonna go to ICU overnight, which is basically my recovery room, and you'll go out to the floor the next morning. In theory, depending on what we do, you could probably even go home. But by the second day would be a safe way of looking at it. So it's, you could think of it as an inpatient procedure.
Which one?
But you won't have an incision here.
Yeah, but you would know more.
I don't think there's any doubt that you'll be complete in the information because you won't be leaving a paucity of tissue. Large amounts of tissue could be brought. First of all, this thing will be completely gone. If you just look at that by itself, that's very suspicious. If I didn't see anything else, that would worry me. That's a spiculated lesion. And in a man your age living in America, that's lung cancer until proven otherwise. Now, if it's coccidiomycosis, that's even better. Now, if you got to try to culture this and grow it, which would be the case with coccidiomycosis, or blastomycosis in your case, the Southwest United States, they deal with cocci the same way you do with blasto up there. Then being able to see it, having adequate amount of tissue, that they can make a number of slides and cultures and stains, you'll get more information from the thoracoscopic approach than you do from the mediastinoscopy. But the mediastinoscopy or thoracoscopy, we're going to the same place. It's just when we go through this pleural space, it's a drive-in theater. I mean, we can see
You see
everything.
it all.
Yeah. I think that lesion is gonna be easy to find, easy to quickly resect and then move right in toward those nodes while the microscope doctor is taking a look at the frozen on that.
Can they tell immediately if it's cancer?
They're gonna be able to tell almost in all circumstances. They may not tell us everything about it, but they'll maybe 90% sure. They'll usually say, unless they come back and say, you know, we're just not sure we see any cancer. Looks infected, and they look granuloma and see a little bit of this, and a little bit of that. We don't actually see malignancy. Well, that's great. We're happy. We start chewing into those two large nodal masses, and then a lot of it will be saved for permanent. The permanent sections go through a process that takes 3 or 4 days, and they'll make hundreds of slides and take a look at it. Because otherwise, you could stick a needle in here.
That's what I thought you were gonna do. And if it's,
I don't do the needles.
you don't, if it is cancer,
He
that
would've-
won't
he
help
would've-
spread it or nothing.
He would have sent you to interventional radiology.
Okay.
If this is cancer in the lung already spread to these lymph nodes in that degree of burden, you're dealing with stage 3B lung cancer already. Spreading it is not an issue. First of all, probably does not happen. But the key here is to find out what the hell it is,
Well, yeah, that's
to
what.
see whether he's got lung cancer.
I mean, look, we've been devastated that when they said, this is cancer. I mean, they said,
Who is they said that?
when
Dr.
Dr.
Duggan.
Duggan came in and said, I'm almost sure it's
Cancer is a diagnosis made under the microscope by the pathologist.
He told
And
me.
until the fat lady
says
sings,
something
so to speak, no offense
It's not
to
cancer.
anyone, it is not defined. That's why either with a needle, or Dr. Nutley through a bronchoscopy, or us going through thoracoscopic access, or down the throat, or through the lung, or through the neck, or wherever to get tissue, that the pathologist can make a diagnosis. Because you've already pointed out, blastomycosis, in fact, is one of those that gets close to looking like cancer even under the microscope. So if you get a bunch of cells, a few cells on a fine needle aspirate, and hey, this kind of looks malignant, turns out you treat aggressively for cancer, only to find out if you had a big enough piece, it would actually prove to be blastomycosis. I don't have to tell you how serious of a mistake that would be. Because you might commit to cisplatin doublet chemotherapy and stereotactic radiotherapy for an infection.
Right.
That's not a good idea.
Well, we've got everybody praying for him, so so far benign, so we'll pray
That's
for
right.
benign.
Well, either
progressive.
one of these are good approaches, except when you go through the neck, you're gonna see that first node cluster. And we can chew on that as much as we can. If we can get a quarter size amount of material out of there and give it to the pathologist. But that's it.
Okay.
You're never gonna see this lesion.
Let's get that.
If we go there, we're in trouble. If we're never gonna get out here, although I told you, whatever this is almost certainly the same thing as what this is.
All right, on the other test, you had it of that, and it said it's not cancerous, not malignant.
No,
Not, is that correct?
The only thing I've told you that was not cancer, again, a pathologist looked at
Sure.
is biopsy brushings, cytology that Dr. Nutley collected going down what he said was the left lower lobe, posterior segment of the left lung. This is not even the left lung.
Well, that's what I've been sitting here thinking about the left lung.
Wonder why they didn't do the right one.
Well, they didn't
Because
see
of
a
that?
mass there.
Oh.
He says he saw a mass in the left lower lobe.
Okay.
Man, we can do this either way.
Okay, well, whatever y'all tell us to do, that's what
That's
we'll,
what we'll do, Doc.
I'll ask him what he wants to do.
I guess y'all call us and we'll know.
I want to see exactly how far this is. The very beginning of this 3 millimeter cuts, that's one click, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. You start running into it right about there. So it's at least 3 centimeters down this far off to the right, the trachea. You'll run into that mass. And that certainly could be done. But this lesion, the lesion here is really of some interest. There's a scenario, if this is benign, or it might be this, a little of that, a little of this, a little of that, they say, okay, well, that's interesting. Now what do we do? Well, what are you gonna treat it with? Not even sure, you don't grow anything, it's just a big ugly node. Well, now you still got this thing. What are you gonna do then? You repeat the CAT scan every 3 months? Go a needle biopsy of that? You see where I'm going with it?
I do, yeah.
If you take that lesion out and put it in the pan, and that's not a cancer, you don't dream about this one anymore. It ain't there.
Sure.
And you get a good chunk of these nodes. I mean, a good chunk. I mean, we can get right on our hands and take pieces of it out in parts, have enough, for everybody to look at. A little more involved, but not terribly so. The cervical mediastinoscopy, again, if this is all you had, you presented like this, that's perfect situation for what we call the legacy or classic mediastinoscopy. Let me see what he said again on this airway. He writes on there 3 and 4. That's where he was, left lower lobe. Biopsy, brush, culture, superior segment, left lower lobe. Pictures of it too.
So this could be,
But if you look down the left lower lobe, in this area, what he's talking about, you don't see anything. The left lower lobe is all along here, and that segment feeds an area up here. You don't see anything at all.
still gotta get in the right to see what he's got.
I think that's when they asked Jesse James why he robbed banks. You know what he said? That's where his money is.
That's right. Well, now, doctor, I've been sitting 21 years ago, 1st of August with my husband. I've seen all x-rays and